All right, let's dive into a topic that is absolutely essential for your exams: traumatic pelvic fractures. This is a high-yield masterclass designed to walk you through the entire patient journey, from the moment they hit the door to their postoperative care. Let's get right into it. First things first, let's talk about the stakes. Why is this so important? Because the overall mortality rate for these injuries is a shocking 5 to 15%. And if the patient is hemodynamically unstable, meaning they're in shock from blood loss, that number climbs even higher. The number one killer here, without a doubt, is massive internal bleeding. So, to really get a grip on this, we're going to follow the patient's journey step by step. We'll start with the anatomy of the pelvis itself, then move to that critical first response in the emergency department. After that, we'll cover how to stop that massive bleed, look at the surgical options, put anesthesia in the hot seat, and finally talk about the big risks after surgery. Okay, let's start with the fundamentals. You can't manage the injury if you don't understand the structure. So let's look at the pelvis and how it breaks. Think of the pelvis as a strong, bony ring that connects your spine to your legs. It's made up of a few key parts. You've got the two big innominate bones on the sides, and they meet the sacrum at the back. Its incredible strength comes from a really powerful network of ligaments. So when we talk about a pelvic fracture, we're not just talking about a broken bone. We're talking about a break in this entire critical ring structure. So how do we classify these breaks? Well, the most common way is the Young and Burgess system, and it's all about the direction of the force that caused the injury. You've got anteroposterior, or AP compression. Think of a head-on car crash. Then there's lateral compression from a side impact, like a T-bone collision. And finally, the most dangerous one, vertical shear, usually from a fall from a great height. That's the most unstable pattern of all.
Now, understanding the type of instability is absolutely key because it tells you everything about the bleeding risk. With rotational instability, you get this classic open book fracture. As the name suggests, the pelvis literally opens up. This dramatically increases the internal volume, creating more space for blood to pour into and preventing any natural pressure or tamponade that might stop the bleeding. Now, if you add vertical instability on top of that, well, you get a complete disruption of the ring, massive soft tissue injury, and the most severe hemorrhage imaginable.
Okay, theory's great, but let's put this into practice. A patient with a suspected pelvic fracture has just been rolled into your emergency department. The clock is ticking. This is the golden hour.
Your initial management has to be systematic, no messing around. We stick to our ATLS protocols to find and fix any immediate life threats. A really crucial early step is to make sure that pelvic binder's on, and on correctly, right over the greater trochanters, to literally squeeze that pelvic volume closed. The patient's stability then dictates our next move. If they're stable, they go for a CT scan. If they're unstable, they might be heading straight to the operating room. And of course, we give them pain relief, usually with IV morphine.
Now, just as important as what you do is what you don't do. These are critical mistakes to avoid. First, never, ever spring the pelvis to check for stability. You could dislodge a fragile, life-saving clot and restart a massive bleed. For the exact same reason, we don't log roll these patients. A straight lift is much safer. And finally, you want to avoid NSAIDs early on. Why? Because they can mess with platelet function and are tough on the kidneys, which are already under stress.
Let's be crystal clear. Hemorrhage is the #1 cause of death in these injuries. So our primary goal is simple and urgent. We have to stop the bleed. So where is all this blood coming from? Most of the time, it's actually low-pressure venous bleeding from this huge network of veins called the presacral plexus, and also from the raw bony fracture surfaces. Arterial injuries are less common, but when they happen, they're absolutely catastrophic. And here's the truly scary part. That retroperitoneal space can hold a person's entire blood volume. We're talking up to 5 liters before any natural tamponade effect can even begin to kick in.
Okay, so you're doing everything right. You're pouring in blood products, the massive hemorrhage protocol is activated, but the patient is still in shock, they're still unresponsive. This is a pivotal moment, and it needs a swift, consultant-led decision. What is the next life-saving move?
You've basically got 2 main pathways here, and the choice often comes down to your hospital's resources and what you can do fast. If you have interventional radiology on hand, angiography with embolization is a fantastic option. They can go in, find the specific bleeding artery, and plug it. The other path is a direct surgical approach. Take the patient to the operating room for an emergency laparotomy and physically pack the pelvis with swabs to apply direct pressure.
So, once that immediate threat to life is under control, the focus shifts to the orthopedic side of things. We need to stabilize that pelvis, first temporarily, and then for the long haul. The first surgical step is often putting on a temporary external fixator, or an X-fix. You can think of it like external scaffolding for the pelvis. Big screws are placed into the iliac crests and connected by rods outside the body. This is a critical damage control procedure. It reduces the fracture, helps close down that pelvic volume to control bleeding, and provides some stability to help with the pain. Now, once the patient is stable and resuscitated, they'll come back to the theater for the final repair. This is the definitive fixation. The goal here is to perfectly put that pelvic ring back together using internal plates and screws. This isn't just about the bone healing. It provides the stability needed for early mobilization, which is absolutely crucial for preventing long-term disability. All right, let's put ourselves in the hot seat. What are the key things that we as anesthetists need to be thinking about when we're managing these incredibly complex cases?
This is a great summary slide for your revision. Let's break it down. Preoperatively, it is all about communication. We're talking to the surgeons, we're cross-matching at least 4 to 6 units of blood, fixing any coagulopathy, and booking that ICU bed early. Intraoperatively, access is king. An arterial line and 2 large-bore IVs are the absolute minimum. If they're going prone, you need a reinforced tube, and we are always giving tranexamic acid. Then, postoperatively, our focus shifts to good multimodal pain relief, which might even include an epidural for certain surgeries.
The patient is safely through surgery, but our job is far from over. Now we have to face one of the biggest postoperative risks, and that's venous thromboembolism, or VTE. Just look at these numbers, they are astronomical. Somewhere between 35 and 60% of patients with major pelvic trauma will develop a deep vein thrombosis. This isn't some minor side issue. This is a primary threat that we have to manage aggressively to prevent a potentially fatal pulmonary embolism. So our prevention strategy has to be aggressive. We start mechanical prophylaxis, like compression devices, pretty much as soon as they're admitted. Then, as soon as the bleeding is under control and their clotting is normalizing, we start chemical prophylaxis, ideally within 24 hours. And remember, getting them to surgery quickly isn't just about fixing the bone. It's also a critical part of preventing these deadly clots. And really, the evidence boils down to this key message. Our best weapon is a 1-2 punch of early thromboprophylaxis and early surgical intervention. You have to be prompt and you have to be proactive.
All the information in this explainer has been drawn from this excellent review article by Akuji and colleagues, which was published in BJA Education back in 2018. I highly recommend adding it to your reading list for a deeper dive into the topic.
So I'll leave you with this final thought to reflect on. We've covered the medicine, the procedures, and the anesthetic plan. But at the end of the day, success in these cases comes down to teamwork in that first golden hour. How do all the different pieces of the puzzle, trauma surgery, anesthesia, radiology, nursing, all come together seamlessly to turn that terrifying mortality statistic into a story of survival?